Good evening, my dear colleagues joining us from all over the world. It might be early good morning or late afternoon or a good evening on this Friday. And I'd like to welcome you to the webinar series jointly hosted by Sri Lanka Dental Association in association with Commonwealth Dental Association. So we have always strived to bring the best as well as the variety of dental specialties and to give you the maximum experience to listen to these eminent speakers from various subspecialties of dentistry. And keeping that in mind, we have invited a guest speaker who is specializing in oral and maxillofacial surgery. So I would like to introduce Dr. Buddhika Dissanayake, uh, who is a consultant oral maxillofacial surgeon based at Provincial General Hospital, Badulla. Dr. Buddhika obtained his bachelor in dental surgery from University of Peradeniya, Sri Lanka, and he obtained his Doctor of Medicine, oral and maxillofacial surgery from University of Colombo. And then he proceeded to United Kingdom, where he obtained further training in James University Hospital in Middlesbrough. Currently, he is practicing at Provincial General Hospital, Badulla, Sri Lanka, and he's the only consultant oral and maxillofacial surgeon for the entire Uva province of Sri Lanka. His main areas of interest is cosmetic facial surgeries as well as facial trauma management. So I think I have done justice to the introduction of Dr. Buddhika Dissanayake. So without taking too much of time, I would like to invite Dr. Buddhika to deliver his lecture. I would also like to remind all the viewers that all the questions should be typed in through the chat, and then it will be forwarded to Dr. Buddhika, and he will be answering questions at the end of the lecture. Over to Buddhika.
Thank you very much, Dr. Siriman Samarkand, for your kind words of introduction. And I think it's a privilege that I have received this opportunity to talk to you in this webinar series, which is organized by Sri Lanka Dental Association in collaboration with Commonwealth Dental Association. And it's a great pleasure for me to come and talk to you all. As Dr. Siriman mentioned, I'm working in General Hospital Badulla and I'm living in Colombo. As you can see here, Badulla is about 250 kilometers far away from Colombo. It's a very beautiful area that is situated at the middle of our beautiful island. So this is my hospital, and you can see the vicinity, which is filled with beautiful mountains, tea estates, and waterfalls. If you all are who are joining us from overseas, if you happen to come to Sri Lanka, please enjoy the beauty of our country. When I was asked about the topic that I should be talking on here, I understood that it is mainly the dental surgeons who are participating for that. So, being an OMF surgeon, what I thought was that I should talk on a topic which is important for their day-to-day practice. Odontogenic infections, the infections that are arising from the tooth and related structures, that is something dental surgeons as well as OMF surgeons we also encountering in our day-to-day practice. So I thought of talking about odontogenic infections. That here, when I was talking with the trainee dental surgeons in my hospital as well as in other places, what I have understood is that they know bits and pieces where about the management and the occurrence of this odontogenic infections, but how they progress and how they what is the level of intervention that we need to attend, and how they would progress, or how we can foresee the end result of that infection is not that much understood by most of the dental surgeons. So it is very important for them to understand that aspect as they are dealing with this. So these infections in orofacial area that are originating from the dental causes. So they are mainly caused by oral flora, obviously, and they are anaerobic, mainly anaerobic and mixed with aerobic bacteria. So they can range from a mild enamel caries to a very severe life-threatening conditions. So it is understood that most of the head and neck infections are originating from dental causes. So it is more than 50%. And more than half of these infections are caused by anaerobic bacteria. So odontogenic infections, they can arise from dental caries and periodontal structures, periodontal infections, and pericoronitis. You know, it is the inflammation of the gum that is surrounding the tooth. In case of odontogenic infections, a dental surgeon must have an ability to identify the origin of the infection and its extent, where it has gone in. And they should be able to foresee how it will progress and what level of intervention that they need to be on for that infection to control that. So progression of odontogenic infections, this is how it will progress. Sometimes it may localize. If our immune system is good, then it will localize an external aid, or it can form a sinus tract which will be discharging, and it can inflame the bone where the tooth is attached. So it can go into the soft tissues and cause cellulitis, form an abscess, and if it goes into the bloodstream, like it will cause bacteremia and septicemia. So it can progress into the distant sites, going through the tissue plates and facial spaces like brain, mediastinum, and if it enters the lymphoid system, it can cause lymphadenopathy, obviously. So this picture shows a decay of a tooth and gums, an infection. So the infection is caused by the balance between the microbial factors and the host factors. Microbial factors are the virulence of the organism and the quantity of the organism that is causing the infection. And host factors are the person's ability, humoral, cellular, innate ability to confront the infection. This picture shows pericoronitis. We'll see how this progresses. Enamel caries. This odontogenic infections, if it is arising from the tooth, will start as enamel caries, and they will progress into the dentine and then again to the pulp. When it enters the pulp, it will cause pulpitis. It could be acute or chronic. And through the pulp, it may enter the periapical area at the tip of the root area. So there it will cause apical periodontitis. And in the inflammation there, acute periodontitis can lead to periapical abscess, or it can end up as periapical granuloma, which will lies in the center and cause periapical cyst. It also can cause the inflammation of the bone, which again will be acute or chronic, acute osteomyelitis or chronic osteomyelitis. And if it comes out, we have seen this many times, if it comes out, it can inflame the periosteum that is surrounding the bone. It is the periostitis. And if it comes through the periosteum into the soft tissues, it will cause cellulitis and abscess, or both. So what are the features in this progression of infection? Enamel caries, we know them. Patient will complain of food packing, or when the dental surgeon is examining it, he will feel probe catching, a visible defect could be there, or discoloration of the tooth is also a feature. And dentinal caries, patient will complain that he or she will be having sensitivity to cold, sour taste, or sweet stimuli. And there could be defect in the tooth structure. There could be food packing, and sometimes they will complain of pain. Acute pulpitis, what are the features? So the patient will be complaining of severe throbbing pain here. And that pain cannot be localized because we know there are no proprioceptive fibers in the pulp. So patient will complain that that side of the face, whole face is painful, or sometimes maybe the head, complain of severe headache and pain, or the pain in that side. And when it goes to the periapical area, what will happen? So it can cause inflammation at the apex of the root, which can be localized. As we have understood now, acute pulpitis, it can't be localized, but here the pain can be localized. Patient will say that particular tooth is giving the trouble, and he or she will say that tooth is, the patient will feel that tooth is elevated above the normal level because of the pressure effect that is happening at the apex area, and the touching of by the opposite tooth will cause severe pain, and there may be tenderness in the overlying bone that is against the affected tooth. Chronic periapical infection or periapical granuloma or a cyst. So that will cause chronic dull pain, which is localized, and there could be swelling if it is large enough. Cyst or granuloma is large enough, it will cause a swelling in the adjacent bone. Acute periostitis. This is important to understand. Here, what will happen is the infection has penetrated the bone and it has come out of the bone, but still underneath the periosteum. So the periosteum gets inflamed and it will cause severe throbbing pain. And sometimes there could be pus collection underneath the periosteum, in between the periosteum and the bone. So pain can be here, the patient will complain of the pain, but because of the pain that is arising from the periosteum, patient can't localize it to the particular place. He or she will complain that whole side is painful, but he will say that it is that particular, whether it is upper jaw or lower jaw, and the side the patient will be able to say. What is cellulitis? When the infection comes out from the bone, it can cause cellulitis. That is the spread of infection through inner layers of the skin against defensive systems. It is important to understand that cellulitis is the mere action of the infective agent. So it is our body is not able to confront it adequately. That is why cellulitis is caused. Abscess, This is the confining. The body is able to confine this infection, and the body's defense mechanism, immune system, is working to confine the infection, and it will lead to abscess formation. So this picture shows cellulitis, which is rapidly progressing, and this picture will shows confined infection, which is the abscess. But abscess is not chronic inflammation, because in case of abscess, the body is not able to control it totally. This abscess, or the pus in the abscess, can track down through tissue plates and cause infection in other sites. Cellulitis is not confined to the tissue planes. It doesn't respect the tissue planes, so the facial spaces, it spreads. But pus that is in abscess will, the formed pus will track down along tissue plates. What are the differences between cellulitis and abscess? This is very important to understand, because cellulitis is more dangerous. Body can't confine the infection here. So the duration is, it is acute. In case of cellulitis, it is the acute phase. Once the body acts on the infection, the abscess can form. So it is a chronic phase. Pain in the cellulitis is more severe, and it is generalized. Abscess, it is localized. Size, the cellulitis is invading a large area, and abscess, it is small relatively. And localization, the cellulitis has diffuse borders. We can't define the borders, but in the case of abscess, it's well circumscribed. Palpation, a dough-like feeling could be felt on palpation, but in case of abscess, it is fluctuant. Presence of pus, yes, in cellulitis, pus is there. Abscess, in cellulitis, pus is not there. In abscess, pus is there. Degree of seriousness, it is greater in cellulitis and less damaging in abscess. Bacteria is basically aerobic in nature in cellulitis, and anaerobic or mixed growth in abscess. So tissue spaces, where the tissue spaces are invaded when the infection, that odontogenic infection, comes into the face, it goes through these tissue spaces, potential tissue spaces. So there are many tissue spaces. It is important for a dental surgeon to have an idea what are the spaces that are invaded by various teeth, infections in various teeth, because it is important in management. It is important in doing drainage. So I have, rather than telling you about what are the tissue spaces and defining their borders, I think it will be more helpful if I tell you what are the tissue spaces that are invaded by the infection from various teeth. First, we'll take the maxillary teeth. So in case of maxillary teeth, we'll take maxillary central incisor first. Infection that is arising from maxillary incisor, where it can go? It can go into the vestibular space that is immediately above the insulcus, that is the vestibular space between the skin and the between the mucosa and underlying orbicularis oris muscle area. And it can go into, if the root is long enough, it can go into nose even. In case of lateral incisor, that is upper lateral incisor, that is almost always going into palatal space. That is the space that is between the palatal mucosa and the palatal bone. In case of canine and the first premolar, the infection can go into canine fossa and the vestibular space. If we know that the first premolar has two roots, if the infection goes through the palatal root, it can go into the palatal space also. And from second premolar onwards, the infection can go into various places. One thing is it can go into vestibular space. We know the buccinator muscle attached to the pterygomandibular raphe from posteriorly, and it comes forward and attached to the bone in the both maxilla and the mandible in the molar region. So if the roots of the teeth are above the level of the buccinator attachment, then it will go into the buccal space. Buccal space is the space, potential space that is in between the buccinator muscle and the skin, and it can go into vestibule space also. If the roots are below the level of the attachment of the buccinator muscle. Another place it can go is maxillary sinus. If the infection goes through the palatal root, what will happen? It will end up in the palatal space between the palatal mucosa and the palatal bone. The posterior, what will happen? During third molar, we know the muscle attachments in the third molar area. So from the medial surface of the lateral pterygoid plate, I don't know whether you can see, the medial pterygoid muscle comes and attached to the angle of the mandible. So between the angle of the mandible and the medial surface of the ramus, there's pterygoid space. So this infection can track down into that space. And infratemporal fossa, that is, this is the temporal bone. So the space that is inferior to the temporal bone is the infratemporal fossa. And nearby is the pterygoid space, that is between the posterior surface of maxilla and the pterygoid plates. Again, it can go into sinuses also, or maxillary sinus also. So that is how infection from the upper jaw, the teeth from the upper jaw can spread. If you take the lower jaw, where can the infection go? When we take mandibular incisors, we know that they're more inclined towards the anterior surface or the lateral surface of the symphysial area. So the infection almost always end up in mentalis area, which causes severe pain there. And if they are going posteriorly, what will happen is they will end up in sublingual space or submental space. In the canine also it's the same. And more posteriorly, what will happen is from premolar, canine, premolars and molars, the infection can go into if the roots of if they are coming outwards, then the buccinator muscle attachment is here, so they can go into vestibular space or buccal space if the roots are ends below the root tips are below the level of the buccinator muscle attachment. They will go into buccal space. And if they are above the level of the buccinator attachment, they will end up in vestibular space. Medially or lingually, what will happen is, we know the mylohyoid muscle attachment. There's a mylohyoid ridge there. So if the roots of these teeth are below the level of the mylohyoid muscle attachment, they will end up in submandibular space, or else they will be in sublingual space. And the sublingual space and the submandibular space are interconnected posteriorly. From where this infection can go, these are primary spaces. Where else it can go? We know that buccinator muscle is attached to pterygomandibular raphe here. Superior constrictor and the buccinator muscle attached at the pterygomandibular raphe. The superior constrictor is forming the pharynx. So the infections in this area can go into parapharyngeal spaces, and the medial pterygoid, and it also can go into pterygoid space. Mostly from the third molar, the infection can go into submasseteric space. We know that submasseter muscle is attached to the zygomatic arch from above and to the angle of the mandible below. So infection from third molar can track up into the space that is between the lateral surface of the ramus and to the medial surface of the masseter muscle, that is the submasseteric space. From there, where it can go, it can track up. So we know the temporalis muscle is attached to the squamous part of the temporal bone and to the zygomatic arch. So the infection that is in the submasseteric space can track up and go into the deep temporal space. The temporal space is divided into two parts. That is the deep temporal space that is between the squamous part of the temporal bone and the temporalis muscle. And there's a superficial temporal space also, that is in between the skin and the or the scalp skin and the temporalis bone. So what are the clinical features that we can see in these infections? Buccal space, we know there's a big swelling in the cheek if it goes into the buccal space. Canine fossa, if the infection is in the canine fossa, it can track up. It will cause periorbital swelling with the cellulitis. And palatal abscess, those things I think you can understand. More importantly, what I would like to say is pterygoid space infection. That is the infection that is between the medial pterygoid muscle and the medial surface of the ramus of the mandible. So when the infection goes there, what will happen is it will push the uvula to the opposite side. And superficial temporal space, there will be bulging that is above the zygomatic arch level. And if it is in the deep temporal space or deep temporal space, there won't be that much of swelling, but patient will complain of severe pain and it is very dangerous. You know about the Terrian area where there's an attachment of 4 skull bones and it is the thinnest area of the skull, and this infection will almost always will penetrate the bone. If it can penetrate the cortical plate of the mandible, this thin area in the skull is not that much of a barrier for infection here. So it is infection that deep temporal space infection is infection that need immediate intervention. And from there, from the infection that goes into the parapharyngeal space, it can track backwards and it can go into retropharyngeal space, and it can go down and go into the mediastinum. So there are many sayings in the literature of surgery. This is one thing: never let the sun go down on undrained pus. That means when there's pus, you should not wait, you should drain. So what are the steps in management of this odontogenic infections? We know that, as we have talked, it can start from periodontium, or else it can start from dental enamel caries. And if it is confined to the tooth structure, our consultants in restorative dentistry, they are managing that. But when it comes out, when it's into the orofacial area, it will be the business of OMF surgeons. And if it goes beyond that, if it goes into the brain, cavernous sinus thrombosis, we know that brain abscesses, mediastinitis, orbital infections could be there. So it is the other specialties. So it is important for a dental surgeon as well as for an OMF surgeon to determine the severity of infection, where the infection, how hospitals can be evaluated. An infection that is there for a long time, say for example 1 week or 2 weeks, which is not that much rapidly progressing. So we can assume that patient's immune system or the defensive system is working very well. But if the patient is having an infection which is rapidly developing, that means we need to intervene very early. The setting of care, are we going to give drugs, antibiotics, and going to see, wait and see, or are we going to give, are we going to do IND, incision drainage, or are we going to admit the patient? So that need to be decided. Treat surgically, support medically. Surgical treatment is always incision and drainage. Medical means we know various measures that we have to take. We have to hydrate the patient, we have to give him medical antibiotics, and we have to evaluate the progress of the infection. And after that also, we have to monitor the patient frequently to see how the response is. So medical management, empirical oral antibiotics could be oral or IV antibiotics. Pain medication, patient is in severe pain and we need to give analgesics. Hydrate, enough hydration, because the patients are not taking enough food or liquids. Nutrition is important. And it is important to control any systemic diseases like diabetes to control the infection, because it impairs the high sugar levels, impairs the immunity. And surgical, remove the dental course. It could be either extraction of the tooth or doing a root canal therapy, incision and drainage, intraoral or extraoral incision. IND we can do. So these are some of the skin incisions that we perform to drain the infections. So if it is in superficial or deep temporal space, we perform incisions here. Submental, under the chin, submandibular area, protecting the marginal mandibular nerve, branch of the facial nerve, and submandibular, submesenteric, and pterygomandibular spaces. We can actually either perform this externally as well as internally also. Lateral pharyngeal space and upper portion of the retropharyngeal space. We are performing near the anterior border of the performing incision near the anterior border of the sternocleidomastoid muscle. So this is intraoral incisions. This I think our dental surgeons are very thorough with. If this is the periostitis, what will happen? In case of periostitis, patient is complaining of severe pain, but you can't see pus. But near an offending tooth, there will be a small bulging. So in this case, I have seen some are trying to get the pus out by forming incisions in the nearby sulcus, but it is not going to work. So direct your number 11 blade towards the bone onto the bulging that is at the near the offending tooth, the bulging of the periosteum. So there you will be able to get a little bit of pus and it will relieve the patient. So this is how we drain a submandibular area infection. Retropharyngeal abscesses. What antibiotics to use? When you are giving empirical antibiotics, it is always better to consider about the potency of the antibiotic, because most of our infections are answering to the simple antibiotics. But if you are going to use more advanced antibiotics, it is always better to get the opinion of the microbiologist, because the misuse of antibiotics is going to be a very critical problem that the humankind is facing in the future. So it is the rational use of antibiotics is almost always advisable. So what to use? What are the antibiotics to use and for how long it should be used? Route of administration, whether it is going to be oral or intravenous. Perioperative cover, are we going to, before the incision and drainage, and during that and post-operatively, are we going to cover that? So increasing the dosage before an IND, incision of drainage. This is something some surgeons practice because incision and drainage itself can cause bacteremia. To cover that, some do increase the dosage of antibiotics and use of probiotics. We know that oral antibiotics, they can kill the gut flora. So to address that, some if you are going to give antibiotics for a long time, it is advisable to give some probiotics also. And use of antacids and antiemetics, that is also useful because some patients can't tolerate. And it is better to get microbiology opinion if you are going to go for advanced antibiotics like vancomycin, etc. So there are some serious complications of odontogenic infections like Ludwig's angina, cavernous sinus thrombosis, orbital infections. These are managed always by OMS surgeons and other specialties. One thing is this Ludwig's angina, which is not uncommon, which is not rare but uncommon. I would like to say a few words about this thing. In Ludwig's angina, there's involvement of bilateral sublingual spaces and submandibular spaces, which can elevate the tongue, and it can cause airway obstruction. So these patients, they are very ill looking, and they get drooling of saliva, and they can't talk. They can't talk properly. The way they talk is called hot potato speech. That means you are keeping a hot potato in your mouth and trying to talk like. And they always try to be seated or standing because they don't want to lie down. If they lie down, what happens is their tongue falls back and obstruct the airway. So it is an important situation. It is a very, very critical situation that prompt action is needed. Thank you very much.
Thank you very much, Dr. Buddhika Dissanayake, for that very informative lecture. I would like to invite participants to drop questions in the chat section if you have any, so we can take it one by one. So there is one question. What is the place of augmentin?
What is the place for augmentin?
Yeah.
Or coemsky clef?
Yes, I think they are referring to that.
Yes. So it is a basic antibiotic that we are using, and amoxicillin for a normal infection. Say for example, patient is having apical periodontitis or a small infection that is in the orofacial area. If amoxicillin is answering, then I would stop there, because you need to go for coamoxiclav if it is not answering. The coamoxiclav is a good antibiotic that is used, but if you can control the infection with more simpler one, then it is the better way.
Regarding the odontogenic infections that you talked about, can you please tell, when you have, especially in deep-seated infections involving the apex of the root in maxilla or mandible, what is the most suitable antibiotic to use?
I would use amoxicillin because it is more simple antibiotic. And if it is not answering only, we can go amoxicillin and metronidazole, because this anaerobic cover is more there in the metronidazole, so that a combination of amoxicillin and metronidazole will be better at the initial stage. And coamoxiclav, it also has anaerobic coverage, so that we can try that. Clindamycin, if patient is allergic to amoxicillin or coamoxiclav, we can go for that, and it has more bone penetration. But always try to use the simple antibiotics. And if we can eradicate the cause, like you said, it is a deep-seated, that is apical infection. So the causation is from the tooth, isn't it? So it is more important to eradicate the cause rather than trying to control it solely by antibiotics. Antibiotics will help, but still you need to eradicate the infection, either through the root, or, as you would understand clearly, we can go through the bone and do a clearance there also if it is not resolving.
Thank you. There's another question which has come by. How safe is it to use IV dexamethasone in pregnant patients with odontogenic infections?
Dexamethasone, it has
IV dexamethasone.
There are various, yeah, but why we are using this? In case of Ludwig's angina, even people say, or some surgeons do not agree that use of dexamethasone. But in case of pregnancy also, if there's a severe ongoing infection, use of dexamethasone will help to subside the cellulitis portion of that infection, which will be more helpful. In my opinion, if there's a threatening to airway with an infection, even if the patient is pregnant, I would use dexamethasone, because nobody has, there's no evidence that it causes problem. I mean, small amount of dexamethasone, that is corticosteroids, not going to cause that much of a problem, because in a severe stressful situation we secrete cortisol more than that people secrete.
So there was another question which come by. It's regarding cellulitis. How to manage if there's cellulitis? I believe what is referring to is in the orofacial region. And in cellulitis, do we have to give antibiotic, then do IND, and then do the culture, or before doing the IND?
Cellulitis, as I have mentioned, cellulitis is the inflammation that is rapidly spreading in the inner layer of the skin. So it is where the body mechanisms are not still active, so that we need to give antibiotics. First, we need to support the patient. That is one thing, because he needs a general fitness to fight the infection. For example, we need to reduce his blood sugar level. If the patient is diabetic, give enough nutrition, hydrate the patient. If the patient is finding it difficult to breathe, give oxygen. Likewise, we need to support the patient generally. That is one thing. And other thing is eradicating the cause of the infection. If there's offend into that, we need to take it out, or take the infection, the origin of the infection out. And other thing is give empirical antibiotics. It is a must, because the cellulitis is spreading, means patient is unable to fight by himself or herself. So we need they need an external help with antibiotics. So give empirical antibiotics. Culture and ABST, I mean, you need to take pus if there is, but in case of cellulitis, it is difficult to find pus. You can go for imaging if you suspect there's a collection like ultrasonography, CT scan. They will be helpful in finding out whether there's a localized focus of pus. If there is any, then it is better to take pus before IND procedure or during IND procedure, and before giving antibiotics. But it is in case of cellulitis, in my opinion, start antibiotics rather than waiting for CT scan or ultrasound scan, or trying to find out pus. Because cellulitis is rapidly spreading, means you need to intervene immediately. If there's pus, go for IND before giving the antibiotics. When you give antibiotics, it will make the pus sterile, but it is almost always better. It is always better if you can take pus before giving antibiotics. But if there's a delay in time, and if you're not sure whether this is cellulitis or there's abscess, whether there's an abscess formation, and you can see only the cellulitis, if it is rapidly spreading, then don't delay to take pus cultures. Straight away give antibiotics and give general support to the patient. Later you can go for that.
Okay. There's another question which has come by. He's asking to explain the trephinization procedure in odontogenic infections. Trephination procedure.
Trepanning procedure.
Yeah.
That is a burr hole.
Yes.
So that is what they are asking.
Yes.
Actually, I haven't done it. Why you make a burr hole? I have no experience in making burr hole in infections into a site where there is an intra-bone infection. I have no experience in that.
Right. Okay. Would you say that it is a common practice now followed, or rather would you say there's a practice going out during these contemporary times?
I haven't practiced that, honestly.
I think I have come to or rather I have gone through the chat for other questions, and we have come to the end of questions. And let me thank Dr. Buddhika Dissanayake for taking his valuable time off from his very busy schedule and participating in this webinar on behalf of all our colleagues who are joining in from not only from Sri Lanka but from all other parts of the world. And we've had a very interesting and insightful lecture on odontogenic infections. Thank you so much, Dr. Buddhika, for your wonderful presentation. And I'd like to wish everybody a good rest of the day.